Now our next speaker is my classmate, my friend Professor A. Ramachandran. He is the President of India Diabetes Research Foundation and Chairman and Managing Director of Ramachandran Diabetic Hospital. He is going to talk to us on primary prevention of diabetes. Over to Ramachandran.
Thank you. Good afternoon, and I thank the organizers, Dr. Krishna Shadri and others for inviting me for this excellent meeting. I just want to discuss with you the next 20 minutes on the randomized control trials on primary prevention, which we have done in India. As you know, this is quite a familiar slide for most of you, and this shows the increasing prevalence of diabetes in India, and we have been doing this for many years. And at this point of time, we found that we have ran out of words to describe the increasing prevalence. We have been writing papers on increasing prevalence, rising prevalence. So I think it's time that we did something about it at this point of time. That's the time the DPP was coming out with their results in the American prevention trial. So at that time, in 2001, we got interested in randomized control trials on primary prevention in the Indian population. When you talk about primary prevention, you can have approaches of different kinds. You can use it for general population as a public health policy, but to do randomized control trials and to prove that you can do primary prevention, you need to take a high-risk population. That's what we have done. So we had, in the last about 10 years, did 3 randomized control trials. And I'll go through the first one and the third one, and the second one I'm not going to talk about because of lack of time. All these are prospective randomized control trials on primary prevention in patients with impaired glucose tolerance. The first one was called the DPP-1, in which we actually randomized people with impaired glucose tolerance to 4 groups: standard care, lifestyle modification, metformin, and a combination of metformin and lifestyle modification. And the results showed that in the control group, we had a 55% conversion of people with IGT to diabetes, while it was 39.3 with lifestyle modification, 40.5 with metformin, and a combination had 39.5. There is no additional benefit. But the separation started at the end of 1 year. So there was a significant reduction in the conversion of diabetes from IGT, lifestyle modification 28.5, metformin 26.4, and combination 28.2, and all was significant. But the important thing about this was that when compared to the other studies which was published at the time, the United States, Finnish population, Japan, and China, we found some important differences. First of all, the age of the population in the Indian study was much, almost a decade younger than the European population, which is quite understandable because the age of onset of diabetes in type 2 diabetes in India is about 43. More importantly, the BMI of our people with the pre-diabetes was 25.7, which should be considered as actually non-obese in the European standards. Therefore, there was a difference in the target of our primary prevention strategy. While in both in the DPP and the Finnish study, they were actually targeting weight reduction, we actually couldn't actually do a target drastic weight reduction, but we used moderate lifestyle modification, as you can see on this column, compared to the intensive lifestyle modification which are actually employed by the DPP and the DFS. And we used much lower doses of metformin. But having said that, we still got significant reduction in the incidence of diabetes. We also had the opportunity to look at some of the baseline abnormalities because there are not many prospective studies among Indian population. The baseline beta cell dysfunction as well as insulin resistance definitely predicted diabetes. If you have a combination of both together, you have a very high rate of conversion of 55%. The other important thing is at this point of time, there has been debate about HbA1c being used as a parameter for diagnosis of type 2 diabetes. So we looked at the predictive value of the baseline variables such as waist circumference, total plasma glucose, HbA1c, beta cell reserve, and the intervention versus control interaction. And we found 3.5 was the odds ratio for HbA1c. So I think at that point, I believe that HbA1c is a good predictor, not only a predictor of type 2 diabetes, but also maybe one of the diagnostic variables for type 2 diabetes in our population. ongoing. Okay, at this point, we wanted to actually scale up our primary prevention strategy. Although there has been many studies on primary prevention and lifestyle modification has been shown to reduce the incidence of type 2 diabetes, this has not been extensively used in many populations except in European countries like Finland and in Southeast Asia and Singapore. So what we did was we tested a new intervention strategy using mobile telephones and using SMS as a mode of a change in behavior. So we tested the effectiveness of mobile messaging or SMS as an alternate method for delivery of educational advice and motivation to achieve lifestyle modification instead of using paramedics, social workers, or dietitians on a one-to-one basis, which is very labor intensive. The model we employed is called the trans-theoretical model for behavioral change. And that was this. And this is actually funded by the UK India Educational Research Fund and was done in collaboration with the Imperial College in London. To just give you an idea of what is the trans-theoretical model, this is a description of behavioral change in the human beings. We go through different stages when you want to change behavior called pre-contemplation, contemplation, preparation, action, and maintenance. And it's actually a cycle because you can go back and relapse. And therefore, we use this model for using the SMS because the groups of messages were sent in the time. So we evaluated that as a primary objective as whether type 2 diabetes can be prevented by SMS. And we have a number of secondary objectives like cardiovascular risk factors, BMI, etc. And the results of the trial of the recruitment was we actually screened 8,741 men. And by the end of the screening, we had 537 people who were then put on a 2-year randomized trial with SMS and the control population. During the screening period, it was very surprising that we had screened 8,741 people within the age of 35 to 55, and with a 2-hour plasma glucose, we had a very high rate of undetected diabetes in this high-risk group, which is actually very high. If you say 50% have already known diabetes, then we're talking about almost 30% diabetes and 31% IGT. So it's pretty high. We also found there's a very high rates of clustering of cardiovascular risk factors. This shows, this is one of the latest data from Indian population showing pretty high clustering, and this clustering shows that this clustering is also dependent upon glucose tolerance. So back to the study. What happened? This is a baseline characteristics showing the randomization was quite successful. There is no difference in, and it's actually represented the population in India. After 2 years of follow-up, did the SMS do anything at all? Did they actually reduce the risk of diabetes? To our surprise, we found there was a 36% relative risk reduction. This is the Cox proportional hazard model showing that the hazard ratio is 0.64, showing that there was a 36% reduction, which is actually more efficient than the one-to-one that we had employed in the previous 2 studies. So the absolute risk reduction was 9%, and the number needed to prevent 1 case of diabetes was about 11, which is pretty cost-effective. So we conclude the intervention significantly reduced the incidence of type 2 diabetes. We also had secondary outcomes. The HDL improved and the diet improved, which actually showed that that is a mechanism. We had epidemiological analysis. See, there has not been many prospective studies in Indian population, so that we could test lots of things. One of the things we tested, and which we actually published last week in Diabetic Medicine, is that whether the hypertriglyceridemic waste phenotype can be a predictor for type 2 diabetes and insulin resistance. The hypothesis is the presence of elevated triglyceride levels along with the central adiposity, which is called the HTWP, be a proxy measure to identify individuals with abnormal lipid metabolism and insulin resistance and predict of type 2 diabetes. And these are the numbers that we had. Isolated hypertriglyceridemia about 12.4, isolated increased waste was in about 37%. A combination of this was about 32%. And then we looked at whether, and that's the numbers that you see, more than 90 and more than 150. And what we found in this was that the linear regression showing how it is connected with insulin resistance. The model 1 is adjusted for age, BMI, family history, etc., showing whether insulin resistance was related to isolated waist circumference, increase in waist circumference, isolated hypertriglyceridemia, a combination. We found that the combination gave the best best fit of 0.38 and 0.23, showing that if you do whatever kind of adjustments, if you combine hypertriglyceridemia with higher waist, it actually depicts a high amount of insulin resistance. This is the Cox proportional hazard for incidence of type 2 diabetes. So the next question is whether that could predict diabetes, and that is very high. It could actually predict diabetes, 1.59 for model 5, which is adjusted for age, BMI, total body mass, and also insulinogenic index. And we found that there is almost 49% increase in the incidence of diabetes if somebody has a combination of hypertriglyceridemia plus higher waist, which is a very good proxy measure of insulin resistance and risk of diabetes. So a combined measurement of waist circumference and the fasting serum triglycerides may help in identifying people at high risk for developing type 2 diabetes among the people who have impaired glucose tolerance. This paper was published again about 2 weeks ago from China, which is the cardiovascular mortality of all-cause mortality and the diabetes incidence in the 23-year follow-up of the Daching study. Very impressive results, and they found that there was actually a significant decrease in mortality and incidence of cardiovascular mortality in those patients who are on the primary prevention diabetes trial. So what we did was, wanted to look at whether there was improvement in cardiovascular risk factors, as well as to look at whether early improvement of glucose tolerance predicts reduced risk of not only incident diabetes, but also improved cardiovascular risk in pre-diabetic Asian Indian men. This is just under publication. This is the slide which you already saw. As you can see, at the end of 6 months, we had changes in impaired glucose tolerance, and some people got diabetes, some people became normal. And what is the numbers? We had 436 people who were still in the follow-up. 37 people had developed diabetes by the end of 6 months. Of this 436, 130 had become normal with the intervention. 306 were continued to have impaired glucose tolerance. And what we found was that by the end of the study, those people who became normal within 6 months had a 75% decrease incidence of type 2 diabetes, which is very impressive, because within 6 months, you will know who is going to develop diabetes in an intervention trial. We also found that the predictors of regression to normal were the oral disposition index, which is a combination of the area under the curve which multiplied by the insulin resistance, which is Matsuda's index, and the oral disposition index predicted the incidence of type 2 diabetes. So insulin resistance and the beta cell activity could predict diabetes. We also found those people who became diabetic, there was a deterioration in the variables such as cholesterol as well as triglyceride. When they become normal, there is an improvement in cardiovascular risk factors. Therefore, we concluded that normal glucose tolerance within a short period of lifestyle intervention was associated with 75% lower incidence of type 2 diabetes. And the predictors of reversal to NGT were better baseline oral disposition index, improvement in oral disposition index, and early reversion to NGT. An improvement of glucose tolerance was associated with the favorable cardiometabolic risk factors, whereas increasing the glucose intolerance resulted in adverse changes. Therefore, finally, mobile phone messages could be a practical, affordable way to deliver lifestyle advice to delay or prevent diabetes. And this is one of the first examples of a clinical outcome using mobile technology. So efforts towards primary preventions are probably worthwhile. I'd like to thank my clinical team, the research team under Dr. Snehalada, and also Professor Johnston, who is my collaborator from Imperial College. Thank you.
Ram, thank you very much, because you have such a huge daily density. And it's great that you have shown very beautifully how it can be, this technology can be utilized for the primary prevention.